Continuamos con el doctor Stewart Tepper y su tema Anecdotes, Headache and COVID-19.
Thank you for sticking with me as we go through this. We'll talk about something that we're very interested in, headache and COVID-19. Again, my disclosures. I don't have any disclosures with respect to COVID-19, however, other than so far, knock on wood, I have not yet been infected. The first descriptions of COVID-19 and its neurologic manifestations came from Wuhan, China. And the Chinese neurologists listed 214 patients with COVID. About 60% were women, and only 13% in that series, which was published in JAMA Neurology, had headache, and only 5% had anosmia. It may be they didn't ask hard enough. It may be that they didn't have a headache medicine specialist really evaluating the patients, and it may be that they didn't test with olfactory stimuli. Because Dr. Patricia Pozo-Rosic, who practices at the Vall d'Hebron Hospital in Barcelona, has presented much more detailed information about COVID-19 and headache, and I'd like to share her work with you. She studied 130 patients with COVID-19 in Barcelona, about 50-50 men and women, average age about 54. But she found headache occurred in 3/4 of the patients, and anosmia occurred in almost half the patients. It turned out the headache was more severe and more similar to migraine if it started before the other manifestations of the COVID-19. If the headache started with the COVID-19, then the character of the headaches was tension type like, mild to moderate. But if the headache started before the COVID-19, then nausea, vomiting, severity, throbbing quality were all frequent features. Why should this happen? Well, we know that SARS-CoV-2 enters through the nasal cavity. It's a respiratory virus going to the lungs and into the bloodstream. That part is quite understandable from the previous SARS epidemic and explains the relationship of SARS-CoV-2 to the severe lung damage that can occur, as well as to the hematologic consequences that can occur in the bloodstream. But as neurologists, we can understand very clearly that the COVID-19, that the SARS-CoV-2 virus can enter the brain through the cribriform plate, spreading via a transsynaptic transfer. It makes perfect sense anatomically for what we see neurologically with COVID-19. And here is what is seen in imaging, the anosmia of COVID-19. And one can see hyperintensity in the bilateral olfactory bulbs and in the posterior portion of the gyrus rectus, because the virus is ascending in the olfactory system. And it resolves when the virus resolves. But the anosmia is part and parcel of how the virus gets into the brain. On the other hand, so on the one hand, you've got going through the cribriform plate, getting into the olfactory cranial nerve and moving into the straight gyrus and causing anosmia. On the other hand, you have activation through the same nasal passages on the first division of the trigeminal nerve, which then can get into the central nervous system and into the meninges. And once the virus gets into the meninges and around the meningeal vessels, it can cause all of the manifestations of migraine with vasodilation and neurogenic inflammation, but it can also cause much more profound damage consistent with meningitis. But obviously, if it activates meningeal mechanisms, the headache is going to be one of the primary symptoms. And that is very clear from the anatomy. There is systemic inflammation, there is local inflammation, there is vasodilation, there is meningeal location, there's everything to cause activation of the final common pathway seen in migraine. Now, interestingly, headache may have some good prognostic implications for COVID-19. This is the silver lining to the cloud. All sorts of inflammatory mediators are elevated and inflammatory markers elevated in COVID-19. Ferritin, C-reactive protein, D-dimer, interleukin-6. But it turns out that Dr. Pozorosek was able to show that if the patient had headache, the interleukin-6 levels were more stable over time in the headache group, suggesting that headache might be a prognostic indicator for a less severe course. CGRP may play a role in the cytokine release syndrome of COVID-19. And zavegepant, the gepant that I showed you that is being tested for acute treatment of migraine and which is delivered nasally, is being tested in a randomized control trial of hospitalized patients at Jefferson Medical Center in the US to see if blocking the CGRP receptor could help terminate or shorten COVID course. What Dr. Pozorosek showed was a shorter course of symptoms and hospitalization if the patient had headache or headache and anosmia. And the course of COVID was shortened by at least a week. Again, this could be related to the fact that the headache was associated with a blunted interleukin response, or it could be some other features that we don't know about, but it is the silver lining to the cloud. What about telemedicine and the impact of COVID in our treatment in neurology? Well, there have been two randomized controlled trials of telemedicine for migraine management. Both of them preceded the COVID-19 pandemic. One was a small study by Deb Friedman in Dallas, and the other a larger study from Europe. But what was found in these studies was that convenience was rated higher, visit times were shorter, and that the number needed to harm was 20,200, meaning that the secondary headaches were found when appropriate. So there was one secondary headache in each group at 12 months, and it appeared that the telemedicine was optimal for managing headaches during a pandemic. And we are trying to incorporate that in our own practices in the United States. So in conclusion, headache is a common symptom in COVID-19 patients, 13% in the Chinese report, 75% in the Barcelona report. Headache and anosmia are likely related as the SARS-CoV-2 virus traverses the cribriform plate to access the central nervous system. Headache may be associated with reduced interleukin levels and shorter clinical course and hospitalization, and this association may be even stronger with headache plus anosmia. Anti-CGRP therapy is being tested to evaluate for outcomes in hospitalized COVID-19 patients, and during the pandemic, telemedicine appears to be safe and effective in treating patients and having them avoid coming in and the potential risk involved to both patient and provider. And I thank you, and we'll turn this over to Dr. Robles.
There's a question for Dr. Tepper in the chat room. A female 32-year-old with migraine background without sporadic aura. Since 1 year ago, she presents recurrent episodes of 1 to 2 per month of orbitary pain, periorbitary pain that lasts for 2 to 3 days with exudative edema, palpebral edema, nasal congestion, and in 2 of these, epistaxis at the end of the episode.
Okay.
Must I think that the trigeminal autonomic cephalea, or because of the data of scleroedema, the epistaxis, and the time of duration, should I think, or should I think about a different pathology?
I think these are all migraine.
Yo pienso que todos estos son migraña.
Epistaxis is commonly described in migraine.
La epistaxis es normalmente descrita en la migraña.
The duration of the attacks at 2 days is migraine.
La duración de los ataques después de 2 días es migraña.
And between 40 and 50% of migraine patients will have cranial autonomic symptoms.
Y de entre el 40 y 45% de los pacientes después de 2 días tendrán síntomas autonómicos.
Although usually more mild and often bilateral, but not always.
Aunque usualmente menos severos y bilaterales, pero no siempre.
So my bet is migraine, not trigeminal autonomic cephalalgia.
Yo diría que esto es migraña, que no es una cefalea trigemino autonómica, que es migraña. They're asking me, sir, if we can do the questions at 4:45.
Sí, por favor, quiero hacer una pregunta. No sé qué está pasando aquí con esta pantalla y esta cosa. Quiero hacer una pregunta.
I have a question, sir.
Yeah,
She says.
Unfortunately, I will need to be leaving in the next 10 minutes, so I can only...
Okay. Él se tiene que ir en 10 minutos.
Sí, ok. Mi pregunta es que con relación a al galganezumat,
In respect to gangalezumab,
y esos anticuerpos monoclonales que tienen una vida media
and
larga,
those monoclonal antibodies
que tienen una vida media larga,
that have a long life,
una vida media larga y que se administran cada 3 meses, que
and
si
that are administered every 3 months,
que si tienen el mismo efecto wearing off como tiene la toxina botulínica, eso es una pregunta.
do they have the same wearing off effect that the botulinic toxin has? That's one question.
Very interesting question.
Muy interesante esa pregunta.
We have seen wearing off in the last week on the monthly monoclonal
Hemos
antibodies.
visto el wearing off en la última semana en los mensuales, los antibióticos monoclónicos.
And in the last week or 2 on the quarterly.
Y en la última semana o 2 en lo que se administra de manera trimestral.
There was an article in Neurology
Hubo un artículo de
published in
neurología
the last year
publicado el año pasado
that documented wearing off for all of the monoclonal antibodies that are being used in neurology.
Documentó el wearing off de todos
And this
que se
appears
están utilizando en neurología.
associated with the biologic activity and not the pharmacokinetic half-life.
Esto se asocia con la actividad biológica y no con la media vida farmacokinética.
So we don't know why, but we have to help patients during
sabemos
the wearing off time.
por qué ocurre esto, pero tenemos que ayudar a los pacientes con este tiempo de wearing off.
Ok, te voy a hacer otra pregunta y es la siguiente.
Okay, I have another question for you.
En los estudios Evolsto, yo quisiera saber
In the Evolso studies, I would like to know.
Okay, que se están incluyendo pacientes pediátricos. ¿Qué pasa con el bloqueo del CGRP por tanto tiempo? Como
Pediatric patients are being included. What is happening to the CGRP blocking for a long time?
En pacientes pediatric population, en pacientes pediátricos, ¿cómo
In
afecta
pediatric
el
patients.
bloqueo del CGRP por
How
tanto
does the CGRP blocking affect?
We don't know in pediatric patients. The studies have not been done.
No lo sabemos en pacientes pediátricos, en poblaciones pediátricas, porque los estudios aún no se han hecho.
In adults, we have
En adultos,
5-year data on
tenemos
erenumab
datos de 5 años en el Randomized
And 3-year data on
3
fremanezumab
años.
and galcanezumab.
And feminine habit galcanism.
And there has
Los
not
otros
been
dos.
any long-term consequence to taking out
Y
the CGRP.
no ha habido consecuencias a largo plazo cuando le quitamos el CGRP.
La otra pregunta que te
The
quiero
other
hacer
question that I have for you.
es la siguiente. Cuando tú ves la data y los
When you see the
resultados de todos los trabajos pivotales y tú
and
ves
the
la
result
diferencia de la
all the work,
respuesta terapéutica
and you
versus el
see
placebo,
the response of the therapeutic response versus the placebo.
no es tanta la diferencia y creo que la única
It is not
diferencia
so
es
much.
que el efecto placebo no se mantiene en el tiempo y
And
no
I
se
think that
justificaría,
the big difference is that placebo effect does not stay in time.
y no se justificaría la costo-efectividad si tú
And the
tienes
cost
una
effectiveness
respuesta que oscila entre un 50 y un 70% de
will
respuesta
not be
también
effective
con el uso de
if only
monoclonal.
the difference is between 50 to 70% with the use of monoclonal that we see today.
Well, it is true the placebo response wears off.
Es cierto que la respuesta de placebo se gasta, it wears off.
And as I showed you, if you just do placebo-subtracted efficacy, you
Y
miss
si haces eficacia sustraída de placebo, entonces te va a faltar
the big picture,
la
which
visión
is
general.
which is efficacy as well as tolerability and safety.
Eficacia así como tolerabilidad y seguridad.
You cannot use just therapeutic gain.
Puedes utilizar solamente la ganancia terapéutica.
And from an efficacy standpoint, it's
Y desde el
most
punto de vista de
useful to look at the
eficacia,
baseline
es más
and then the
útil
reduction from
ver la línea
baseline,
basal y la reducción a partir de la línea basal,
because you're not going to give your patients placebo.
porque no le vas a dar placebo a tus pacientes.
And the reduction in mean monthly migraine days is about
Y la
half
reducción media en días de migraña es como la mitad
by 3 months.
por 3
And
meses.
you are talking over a
Y
year
estás
of
hablando
3 months or
de más
more of
de
no
un
headache compared to what the patient would have had
3
without treatment.
años o más sin dolores de cabeza, y compara eso con lo que le pasaría a un paciente que no tenga tratamiento.
No tienes diferencia cuando usas un monoclonal que
There's
actúa
no difference when you
en
ask a
el
monoclonal,
ligando o en el
a
receptor.
monoclonal that acts on the receptor.
We don't see any efficacy difference
No vemos
between
diferencia de
receptor and
eficacia
anti-ligand.
entre receptor y antiligand.
However,
Antiligand.
we have many,
embargo,
many patients who have
tenemos
not responded to an anti-receptor
pacientes que
monoclonal
no
antibody who do respond to an
responden
anti-ligand,
a un receptor monoclónico
and
y
the
sí responden a un
reverse.
antiligante, y al revés,
We do think constipation is more
Pensamos
frequent with the
que
anti-receptor
el
monoclonal antibody.
estreñimiento es más común con el antirreceptor.
Muy bien, muchísimas
Very
gracias.
good. Thank you so much, sir.
No hay más, hice tantas preguntas porque no vi más preguntas en el chat.
I put in my own questions because I saw no questions in the chat.
Sí, y otra cosa, te quería preguntar, Steph.
I wanted to ask you also.
Tú sabes que a partir de clonación de ratas,
You know
conseguimos
that
la mayoría
after
de anticuerpos
clonation
monoclonales, sean
rats,
humanizados o no.
we get most antibodies, monoclonal antibodies.
Sean humanizados o no,
Be them
pero
humanized or not.
Eptinezumab se obtiene
But
a
in the
partir
Versumab, you obtain both.
de levaduras recombinantes. Si hay alguna
Recombinant.
diferencia en que se obtengan
Is there a
a
difference?
partir de levadura versus a
Can
partir
you
de la
obtain
obtención
them based on
de las ratas.
brewers in comparison to rats?
I don't think I understood the question. Is there a difference in human response versus rat response? Is that the question?
Okay. As you know, the Eptinezumab is for the fungus. Fungus. No.
Yeast.
Okay.
Yeast.
El Eptinezumab.
Oh, the yeast issue. Yeah. Yes, it is true. Eptinezumab is made with
Sí, es
yeast and
cierto,
the
la
others are
clonal es
not.
hecho con levadura y los otros no lo son.
Doesn't look like it makes any difference.
No
Hasn't
parece
made
que
any
haya ninguna
difference.
diferencia.
Allergic reaction can occur
Reacciones
with any of the
alérgicas pueden
four,
ocurrir,
including angioedema.
incluyendo angioedema.
In my experience with eptinezumab, I've
En mi
not seen more
experiencia
or
con el
less
eculizumab, no he visto más o menos.
adverse events.
O sea, en
I
cuanto a
do see a
eventos adversos,
faster onset with
veo
eptinezumab. It's
un
so
inicio más
fast that it's
rápido
being
con el
studied
eculizumab.
for acute treatment of migraine as
Tan
well.
rápido que está siendo estudiado para tratamiento de migraña aguda también.
Y si tienes monoclonales que
And
tienen
if you have
todos
monoclonals,
una vida media de 28 días
they have
y
a mean
los
life of
tratamientos se
28
duran hasta
days,
3 meses,
and the treatment
esto
is
es
up to 3 months.
porque se ha demostrado la presencia de anticuerpos circulantes incluso después
Have
de
we demonstrated
de la vida
the
media.
presence of circulating antibodies?
There has been a very careful look
Sí.
for neutralizing
Se ha
antibodies,
buscado
and the rate has
anticuerpos
been
neutralizantes.
extremely low, and it is not, there's not been any tachyphylaxis or problem with neutralizing antibodies that so far turned up in the studies or in reports. Of course, there are neutralizing antibodies to onabotulinum toxin A, and so far, even after all these years of using it, we don't know whether they have consequence or not. But the neutralizing antibodies with the monoclonals have been very, very low, very infrequent.
Thank you, and thank you for accept the invitation.
Gracias, and thank you so much for inviting me. I hope we can see each other in person. It's such an honor. Thank you, and have a great Congress.
Thank you.
Bye-bye.